Hello, I'm Janice Karen, Director of Policy, Technology, and Innovation at the Massachusetts Health Data Consortium, or MHDC. I run our Data Governance Collaborative, also known as the DGC. We start each of our weekly meetings with a series of industry quick updates to learn about new and proposed regulations, laws, standards, industry initiatives, and other activity. Join us for this week's updates. Let's go ahead and go to the first update if you don't mind. So this won't have a huge effect on us as far as I can tell, but just so folks know, there is another CMS proposed rule basically requiring that DACA recipients be covered by federal programs and be eligible for financial assistance on the marketplace. The one data piece is that there is going to be a new open enrollment period specifically for this. However, it seems to coincide pretty closely with the normal open enrollment period, so I'm not sure exactly how much extra effort that will entail. But in any case, you can read the press release and have a link to the full NPRM there. And I don't know if it's been published yet or not, but it is supposed to get formally published today and be effective on November 1st. Any questions, thoughts, comments there? All right, let's move on to the next one. So CMS has put out a report with 2021 data based on for disparities in Medicare Advantage. They just sort of did some level setting before they went into it. And they talked about, they sort of compared the racial, ethnic, and gender statistics for fee-for-service versus Medicare Advantage. And the upshot of that comparison is that fee-for-service is both whiter and more male than Medicare Advantage. So Medicare Advantage definitely has a higher percentage of women and a higher percentage of minorities. Now, this report covers two different types of measures, 7 patient measures and 37 clinical care measures. They are not at all careful about specifying when they're talking about one versus the other. And there are some places where you can infer that because they talk about specific number of measures, but in other cases you really can't. So bear in mind that some of these comments may apply to one or the other, and not sure which one that is. But so bearing that in mind, and so in a general sense, some of the key takeaways was that white and Native American populations were similar to the national averages on all of the measures that they looked at. And again, when they say all measures, it's not clear if they mean all measures from both categories or the measures from one category or the other. Black and Hispanic patients were below average on one of the measures and similar on the rest. For some reason, they use AA/NHPI instead of AAPI, but it's basically, as far as I can tell, the same population. So interestingly, they were below average on 6 of the measures and above on 1. I suspect this is, since they talked, I suspect that these first batches of things are on the 7 patient measures. For instance, that one is 7 measures, so it makes sense that they're talking about that. But again, they didn't specify. Female enrollees were similar to the national averages on all of the measures. Male enrollees were below it for 1 measure and above it for 3. And then they did a deeper dive and they looked at looking at all of the factors together. So male versus female in each of the race and ethnicity groups. And in most cases, they found no differences between male and female enrollees, except that for people who identified as multiracial, the male multiracial people consistently perform worse than the female multiracial people. And again, in the AIPI, the male, in that case, the men perform better than female. There was no commentary, and I did not read the entire report. I looked at the highlights and the overviews and the consensuses and stuff like that, summaries. And in those sections, they did not talk at all about other types of gender identity or how they made classifications. It was all male and female. So take from that what you will, considering that it's looking at health equity and disparities. I'm sure that's because that's the data they had available, but it did strike me as a glaring note when they're looking at disparities and health equity that they did not look at all, or even address it, even if they said we could not address this because of that. And again, maybe they did down in a really detailed section of the report that I did not have a chance to read, but certainly in any of the general discussions about the results, they did not do that. So any comments or thoughts or questions here? All right, if you'd like to dig in more, you can find the full report at that link. Let's move on to the next topic. So this one's really interesting. The FTC has sent out about 670 notices to a large variety of companies of all sizes in a variety of areas related to over-the-counter drugs, homeopathic products, dietary supplements, and functional foods. And while they highlighted the manufacturers, they also sent it to companies like Amazon, really all over the sun. And basically what they said was that some of their advertising might contain unsubstantiated claims, and that's not okay. And some of the things that they said generated these notices were not having a reasonable basis for the claims consisting of competent and reliable evidence for things that should be objective claims, not having scientific evidence to support health or safety claims, not having human clinical trials for products that were intended to treat disease, misrepresenting the level or type of substantiation that they actually did have. So for instance, saying that they had a clinical trial or some type of study when it was not really true. And again, misrepresenting that a claim has been scientifically or clinically proven. So some of those are pretty big deals. So these warnings are important because once they send these notices out, they have the right to start fining people about these things. And while $50,000 is not a lot of money for a company like, say, Amazon, it's per instance, so that can add up fast. You can read more about this, and hopefully it's at least a first step in the process of getting more realistic claims for any health-related advertising. Any comments or thoughts there? Well, I'll add one more thing before we move on. This did not cover, as far as I can tell, any prescription drug advertising. I am not a fan of prescription drug advertising. I wish it were not allowed, but it is not clear to me whether there is a lot more control over what is stated in those ads versus other advertising, and that's why they were not included, or if they're not as directly, so that part of it was not clear to me, but I do want to point out that this did not cover any prescription medication, only over-the-counter medications. All right, let's move on. So the FTC also put out an alert. This one's really interesting. There are fake ads for AI things that are spreading malware. So basically what people are doing is taking advantage of all of the hype on AI, and they're basically putting bogus ads on social media platforms, websites, and other places that contain links to either, sometimes they're clone sites that download malware. Sometimes they're legitimate links, but there's a side pathway that downloads malware on the device. So even when the websites themselves go to the wrong place, a lot of the products they're advertising are real. The ads themselves don't harm your system. So if you get served a bad ad, it's not going to do anything. You have to actually click and do something. So think of it like a phishing attack. If you don't actually respond to it, it doesn't harm you. But basically, you should be, what they're recommending is that you never download any software by following a link. You should always go to the website or the App Store and download it directly. And they caution you as well about using search to find it. If you don't know the manufacturer, be very cautious, because a lot of these false sites will get advertising, and they're willing to pay to get promoted. So some of the links that you'll get back from Google or other search sites may be the bad link and not the legitimate one. And as of right now, a lot of these ads evade systems that are designed to detect malicious advertising, and they also evade most antivirus software. So just be very cautious about this. Any comments or questions or thoughts? All right, let's move on then. So continuing on the AI front, although in a different vein, the FTC, Department of Justice, Civil Rights Division, Consumer Fraud Protection Bureau, and the Equal Employment Opportunity Commission have put out a joint statement that is talking about the federal government as a whole's efforts to look at fairness in AI and some of the oversight authorities that they have around AI and automation. You'll note that there's nothing specific to HHS here, but obviously the FTC controls a lot of technology and healthcare pieces from that perspective. And it talks about some of the recent ongoing work around fairness, preventing discrimination, and risk mitigation. And it talks about some of the different sources of discrimination, like, the data and data sets, the lack of transparency in models, even sometimes to developers who are using them, and some of the design issues and lack of understanding. So there's nothing new there, other than the fact that the federal government is really starting to come down on, this is something we're focusing on, you should pay attention, we're paying attention, and therefore expect more activity in this area from us, and this is what we're looking to do right now. So you can find the announcement about their efforts and some of what they are doing and have the ability to do under their current enforcement rights at that link. Any comments or questions there? All right, then let's move on. So the Administration for Strategic Preparedness and Response has developed excuse me, a new version of the National Health Security Plan. They're required to do this every 4 years. So this new plan covers 2023 to 2026, and it basically highlights 3 major goals. They're kind of no-brainers, but strengthen the healthcare and public health systems to prepare for and respond to multiple concurrent health emergencies. Basically being able to deal with more than one threat at a time, or more than one emergency at a time. Improving the ability to safeguard against things like infectious disease and other emergencies, and having a more sustainable and resilient public health industrial base and supply chain. So none of those should be surprising to anyone. Also not surprising, given what those goals are, is that this version of the plan is basically integrating lessons learned from COVID. They talk about a bunch of different specific threats that they're concerned about. This is not the entire list, but the main things were emerging infectious diseases, climate change, chemical and biological, nuclear threats, cyber attacks, and being able to deal with multiple major emergencies and disasters at the same time. So you can find the official webpage, which has various information and links about this plan there. And anyone have any comments or thoughts or questions here?
Yeah, did they say anything about exactly what kind of strengthening of systems should occur?
You know, I did not, as with many of the things I put here, I have not read the entire report yet. I did not get to the point where I'm not sure is really the answer.
Okay, so that's fine. I'd be interested to see if they mention data interoperability at all in that part of the report.
You know, that's actually a good point, because it certainly is something that they should, in theory, be talking about. I will make a note to take a look and report back.
Thanks.
All right. Any other comments or thoughts there? All right, let's move on to the next item then. So CISA and the NSA have put out a report on the best practices for identity and access management. This is aimed at the implementation side, at system administrators and people who are looking to stand up systems to manage the identity and access control. And they were looking at highly likely or highly impactful threats, or both. So they were really looking at the things that would do the most likely to do damage. And a partial list of the things that they were looking at mitigating were looking at people who were assuming control of accounts of former employees which were not suspended when employees were terminated. I don't actually know how often that happens, but that's actually an interesting thought. Looking at forged authentication assertions like bad OAuth 2 tokens and things like that. Exploiting or utilizing existing users with legitimate access. So that would be things like phishing attacks or things like that, where you get control of an actual legitimate user's login details. Also compromised passwords. So I get so they actually call that out specifically as well. Getting system access and getting access to the whole plethora of credentials, as opposed to violating or getting control of one individual's information. Exploiting default passwords and exploiting deprecated encryption. And I thought it was interesting that they called out the last one, because that's one that's probably all over the place. I would say that most people who are, I'm not saying that there are organizations that always 100% of the time remove everyone's old credentials right away. And there are often, for instance, decisions to keep certain portions of their accounts open for a period, such as incoming email addresses get forwarded to someone else or things like that. But most companies are, at least know they should, and are reasonably decent about removing the basic credentials of employees from certainly from their major systems. Most places are pretty good about changing the default password of something that they install. Deprecated encryption, that one, I don't know how often that's on someone's radar. But obviously these are all things that can happen. And so some of it's common sense and some of it's going into a lot more detail about specific acts that you can take. Again, I have not read every single bit of this report at this point in time. But having said that, any questions, thoughts, comments? All right, let's move on then. All right, so I have to apologize, and one of our attendees was looking through the slides ahead of time and went and got more information to look at more information on this topic. And I believe that I slightly misread it, and she pointed the possibility out to me. So be aware So this is a notice that HHS OCR put out about enforcement discretion around HIPAA during the public health emergency. And you can see on the second bullet that I say there's a 90-day grace period before enforcement resumes. That actually only applies to telehealth. The other components of this do not have the grace period, as far as I can tell. I have a note to further, this just came up this morning, obviously. So I have a note to further confirm that. But based on a reading of the report, it looks like I just misread that, and I apologize. So the other three things, the HIPAA rules for community-based testing sites, the use and disclosure of PHI by business associates for public health activities, and online and web scheduling of vaccination appointments. My belief is that all of those enforcement discretions go away as of May 12th. May 11th is the last day of the public health emergency. But the telehealth and remote communications enforcement discretion is the one that will be extended through August 9th. And thank you very much for pointing out my mistake. I apologize to everyone. So any comments or thoughts about any of that? All right, then let's move on. If you'll pause there for a moment. I hope you learned a lot from our quick updates. If you're interested in finding out more about the DGC and its other activities, email me at dgc@myhealthdata.org. That email address is also on your screen.